Today, I'm going to go over just a really high-level overview of the department that I work for, talk about our key technology efforts, the reportable projects we're doing today, and then talk about some that we're actually starting to spec out and work on for the submittal process here shortly, and then we'll open it up for Q&A. We're kind of like an unknown. We were originally called, well, we've been called many names, but yeah, depending on our patients or who you speak to. But we were the Department of Mental Health, and we had everything that we're responsible for now, but we also had oversight for county mental health programs. In the 2012-2013 budget, the governor split off that, moved that to various departments and Health and Human Services agency like Department of Healthcare Services, and then created the Department of State Hospitals. At the time, when I would call vendors and reach out to people, they were like always surprised because they thought that I no longer work for an organization that exists and we had gone away. But we're, and I'll show in a few minutes, surprisingly, I think we're like the third largest department in the state at this time. So we're kind of like one of these really unknown that exist out there. When we became the Department of State Hospitals, primary, ironically, about 80% of our focus, our work for the department had been on the county-related stuff, and only about 20 for our hospitals. And so it created a very unique environment where our hospitals were kind of left to their own to run as standalone, unique hospitals, which is actually really common. You'll find that exists even with early days of like Kaiser and so on. You could equate our hospitals and how they were siloed, similar to the way the prisons used to be with CDCR, where the warden of a prison was basically the emperor and responsible for everything, and they still are today, but they're now, even CDCR is moving more towards a system perspective. So we provide mental health services to patients that are committed to us by courts. They're committed to us for either a civil or a criminal court. We have 5 very large hospitals and 3 psychiatric programs. I'm not going to read this slide to you, but I'll go to the next, which shows our locations. We have 4 facilities in the north. Napa is the 3rd largest mental health hospital in the world, and it's about 418 acres. It's huge. The secure treatment area, where we treat the most dangerous patients that have been committed for criminal crime, is about a 70-acre area, and has a Sally Port and correctional officers, peace officers that work for us that actually control the entrance and exit. And it looks very much like a prison, other than it's got peacocks that walk all over the place and a roving group of turkeys with one rooster who thinks he's a turkey, but nobody's able to actually convince him otherwise. So he's in Renton? He is. So it's an interesting place to go sit on a bench and eat your lunch. We have a psychiatric facility in Vacaville and Stockton, and also at Salinas. We have an agreement with CDCR and corrections, and so we run smaller psychiatric facilities on those 3 prison sites. In the Central Valley also, we have Coalinga and Atascadero, which are very, very large, huge hospitals. And then in the southern part of the state, we have Metropolitan Patton. Patton's the largest mental health hospital in the world, and is about 450 acres. It's a huge, huge place. It looks like what you would imagine like a Pearl Harbor military base would look like. When you go there, there's palm trees all over the place and old kind of military-looking, buildings. We're 12,201 employees. We have roughly, it fluctuates, 6,500 plus licensed patient beds. This is Bill's slide. We have 24/7 hospital system and an annual budget of about $1.6 billion. This was a real surprise to me. I have, for the past 3.5 years, told everybody we're the 5th largest department in the state. And then one of my staff yesterday said, no, we're 2nd. So I decided to actually go out and look at State Controller's Office and Department of Finance and capture, and found out we're actually number 3. So I was really surprised to see that. So go number 3, and you know. So, and it's also kind of cool to look and see that I've worked at least 4 of these organizations as in a leadership role. All right, so this is kind of confusing, and I'll explain it. It says that we serve more than 12,000 unique patients a year. That's because we have patients that, one, may actually be with us forever, but we also have patients that may come in for like a 90-day period of time. They're incompetent to stand trial. Our job is to evaluate them and to get them to a point where they can actually participate in their trial, and then we put them back to the county that sent them to us. Decades ago, we used to be a very different organization. About half of our patients were civil commitments. These are people that have not committed a crime, but they're really not individuals that you really want walking around, you know, on the streets. And so they would be committed by a civil court to us. And then at the time, about half of our patients were criminal. And it changed, I'm not sure when, I think it was in the 90s where those numbers started to change rapidly. So now today, we're considered what's called a forensic hospital system. And I went online and tried to find a really good definition of that, and there really isn't. But it's basically, we are a hospital system that is a cross between, I'd say, a mental health hospital and also almost like a prison, but not, we don't call our patients inmates, and most of the time they're not shackled or restrained. They do, in the most part, they're inside of secure areas with razor wire, and it looks like a prison, but it is a very different environment. But so now about 90% of our patients are forensic commitments that have come in and they're committed to DSH for a crime. I hear different things in my department. A lot of people will say that they're actually have committed potentially a violent felony, which is a good portion of them, as well as being mentally ill. In addition to forensic commitments, we also house and treat the sexually violent predators. We do that primarily at our Coalinga Hospital, and a pretty good sized, large population down there, and a very interesting hospital to take care of and support. The remainder now, and oddly enough, the smallest number of our population are the civil commitments. The private sector has, and counties have really started to take on those types of individuals. And so if you go to like Napa and our other hospitals, you'll find civilly committed individuals, but it's a really, really small amount. I think it's like 4, 5, 6% of our overall population of patients statewide. And they're not kept in the secure treatment area. They're actually outside and in the normal part of our hospitals. Some of the challenges that we face, increasing patient populations. We are growing all the time, and we are the largest in the US for a state-run mental health organization, and the number of patients. Matter of fact, I think that I've heard different statements where if you add like 40 of the 50 states together, the number of patients that they have, they're still less than us. So it's really hard for us to find benchmarking for what we do. What we actually find is most states come to us. The only states that even come close to us are like Texas and New York, but they're still significantly less. Ironically, my own staffing numbers and budget are actually more than most state mental health run programs. So kind of an interesting thing to see. But we have wait lists, and this is one of our biggest challenges where we are challenged right now, and some of my people are in the audience where their jobs are to roll out a case management system for what we call bed stratification. Up till this time, a judge will assign a patient to a named hospital, and for the very first time, and well, what the problem with that is you may not have vacancies at that hospital. So what happens then is these people literally go into a parking lot type of waiting where they're stuck in a jail somewhere, and they're not getting care, and and the court starts to get very mad with us because we're not keeping with what we're required to do timelines to get these people in. So for the very first time, we have a case management system called Parts that we're rolling out. It's just based on Microsoft technologies, and we really could not find anything off the shelf that would meet California's needs. I know that most people say those things, but where are you going to find a technology that basically manages like 35 penal codes of commitments and stuff? It just doesn't happen. So we are developing this. We're focusing first on the incompetent to stand trial. And then once that's complete and we're running basically a statewide bed management program through that, then we'll start rolling in additional commitment types. And so eventually when a patient comes to us, this will be their entry technology into our department, and this is how we'll place them. Recruitment is a huge problem for us. Napa State Hospitals, I'm not sure if this is still an accurate figure, but the last time I checked, just for primary care physicians, we were running 50% vacancy rates. If you look at our ability to hire psychiatrists, psychologists, nursing staff, and so on, very similar types of vacancy rates. We're having to be very creative in how we recruit people. We're doing things like actually traveling to places like New Jersey and telling them, come to California and we'll actually help you pay for your student loans. And people in New Jersey actually look at California and like, oh, cool, and we don't realize, or they don't realize we're actually potentially sending them to Coaling and Ash. But so those are not bad places. It's always kind of a, yeah. So it's true. We brand ourselves with photos from Napa. So it's like, yes, this is what all of our hospitals look like. Napa, of course it says Napa, but that's not really Napa. So we're doing some really unique things in this area using telepsychiatry and telehealth. So like as an example, we do not have problems hiring in these types of positions down in the Los Angeles region. So what we've done, and it's not fix-all, but it at least helps stem some of the bleeding. What we'll do is move some of the vacancies to like Patton and Metro down in the Los Angeles area, and then have really good, strong teletechnology that these people can deliver telepsychiatry and other types of care to our patients. It's working. Really unique though, telepsychiatry is very different than telemedicine. With telepsychiatry, I was really surprised to find, like as an example, quality of video is paramount. You can never have things like pixelation and so on. And so the quality has to be super high. And the reason for that, and I'm always amazed to find these things out, is it'll actually, a patient may see that and maybe in a delusional state and actually think the clinician is like demonically possessed and have an adverse reaction as a result of the delivery of care. So these are things that we have to take into account and so on. And so it's probably one of the more unique CIO jobs I've ever done before. So the next thing that we have challenges with are basically organizational change. So if you have a state of hospitals where they've been allowed up to a certain point to kind of run as their own, uniformity is basically not a word that's spoken very much. And so they basically all run in a different manner, everything. And so if you look at, like as an example, rolling out, let's say, a pharmacy system, every hospital has what are called SIG codes. And the SIG codes, if you look at your bottles of medicine at home, will basically say take 2 times daily. So it basically tells you the quantity and how often you take it. They're pretty much the same instructions at each hospital, but every one of them actually has numeric codes assigned to them. They're like lookup codes, and the clinicians in those hospitals who have been there for a long time have memorized these codes. All the hospitals are different. And so to roll out a pharmacy system, one of the things we'd have to do is to have uniform SIG codes. you'd have this huge organizational change issue of having everybody start using the same and so on. And so everywhere we look, this is what we're faced with. And so when we're rolling out enterprise technology projects, we find that we have a lot of upfront business process reengineering projects that we have to do to make it even possible to roll out the technology. In this job, I actually do very little technology. Myself and a few of my managers are very much responsible for teaching the organization governance, organizational change, and so on. And we do a lot of smaller projects where then we market to the leadership that I'm a part of what happens in those projects. So they're then prepared for the amount of change they're going to have to incorporate and go through for things like an electronic health record. So one of the projects we're doing right now is Assist, which is our statewide staff scheduling system, and I'll go into it in a minute. And what we discovered when we rolled it out, or started to roll it out, is 25 to 30% of our staff don't know how to use a PC. And you would think in this day and age that people would be far more adept at this, but actually I find in the healthcare industry, this is actually a very common percentage. That when we went around and met with like Adventist Health and different hospital systems, they basically said it was the biggest gotcha that they found, that they just assumed that their people would know how to use this stuff. And they found literally almost a third of their people didn't. So we have surveys that we're doing of all of our staff, finding out where they actually are, and then developing custom and tuned basically development strategies for them to get them up to a point where when we do transition from paper to the electronic world for patient records, they can actually operate effectively. So that's just one example. The last thing is violent and dangerous patients. And I'm going to show you a slide in a second that I think is a real eye-opener. So this was developed by one of my managers who's in the room. And this is one of the biggest problems that myself and my peers are tasked with changing. And so the blue bars are assaults on patients by patients. And so there's 2010, 2011, 2012, 2013. Look at the numbers. But you also see that it's stepping down. So we have been applying clinical and operational changes that have affected this. Also, we're also rolling out the duress alarm system statewide that's helped as well. But the really, really bad is look at the orange. These are basically patient on staff assaults. And so look at this, it's 2703, 2814, 3026, and 2586. It's going up or staying current. And so you'll read in the paper that we are a dangerous environment. So I mean, and I always tell people, imagine going to Kaiser and, in the room next to you, the patient's attacking the doctor. And, and that's very, a friend of mine told me that it's not my daughter applied to Napa. And my friend said, "What are you thinking? What kind of father are you?" And I didn't realize I had to, and it was kind of, I wasn't expecting that. And I said, "Well, what do you mean?" And they said, "Well, it's not a matter of if, it's a matter of when you're going to be attacked. Do you really want your daughter to be attacked?" And, and I then tried to explain that trying to get my daughter to do anything that I want her to do versus what she wants to do is virtually impossible. So, and God help any patient that actually was to attack her. So I mean, this presents a huge problem for us, and has culminated in 2010 in Napa. One of our psych techs, Donna was actually murdered by a patient. And so this is about when I came on to the department, and I took on then the hospital personal duress alarm system project, which was a really, really unique project because it's probably one of the largest RFID projects in California. And it's designed basically to track the whereabouts of each of our staff at all times. And then, and I messed up, hold on one second. I was supposed to have a prop. So this is the tag. And all of our staff wear this. And it is basically, and I'll get into it in a minute what it is, but this is how we track our staff and how they basically call for help if there's a problem. So that was driven by Donna's murder. We piloted at Napa, and then now we've completed 2 of the other hospitals, and we're finishing in the 2 remaining. I'll go into more detail. Then I talked about our staff scheduling project, and then our medical grade network project. And these are our 3 large reportable projects that we have today. So as you see on the screen on the left, this is the tag that I'm wearing. And then you can see how the clinicians wear it. We've developed a carabiner that they can wear it upon. It's effective, I just don't think it's as effective because and I'll kind of get into that. One, this is bidirectional, meaning that when you pull down on this, that's how it triggers the alarm. The people in the area, their tags go off, and it actually displays the telemetry of whose alarm and where they are. And we've turned the people in the local area, your coworkers, into the first responders. And so it actually functions as kind of like a little mini computer with an inbox and a display. It's kind of cool, unless you have bad eyesight like me, and so you have to run around and put glasses on as you're responding to people. So each employee at the hospital is equipped with one of these. I talked about basically pulling on. It will send into the police dispatch these walls with huge monitors. It'll show the exact floor plan with the location of where the alarm is. It'll actually show, it's like watching a sim game. You'll see icons representing everybody in that building, and you'll get to watch them real time as they're actually responding. It's really wild to watch. And it records all this. And so this is all incredible data for us to use at a later time. The police dispatch, it actually sends a message to the person who's activated the alarm that help is on the way and that their alarm has been acknowledged. And then all the staff in the local area descend and actually help. When we went live at Napa the first day, I was standing in the secure treatment area with the executive director, the woman who runs the hospital there, Dolly, and we were really tired. We'd been up for like 24 hours. And we were watching, just kind of in a dazed state, this group of patients playing soccer, and they were being watched by about 4 or 5 of our staff. And suddenly our alarm started going off that someone had triggered an alarm, and it was out in the middle of the field. And so we're like looking around, and everybody's still playing soccer, so we didn't know what was going on. And it said that it was someone named Vincent. And then we watched, and all the buildings that were around the field, people started pouring out of them, and they were coming out onto the field, yelling out Vincent's name, and then police cars and bicycles and everybody, and it really scared the hell out of Vincent. And it turned out Vincent was reffing the game, and it had inadvertently triggered his alarm. But the really cool thing, though, that we saw, and Dolly and I were like the only ones that kind of got it at that moment, we were so happy because the day before there had been no alarm coverage out there at all. And so for the very first time, they had coverage outside in the secure treatment area. Prior, they only had alarms inside of the buildings. Secondly, people actually understood how to use this system, and it was working. For the very first time, you didn't have to wait for police to come. Your coworkers were coming, and they've been trained to basically lend assistance, and they were. And so we saw it work. I mean, it was a false alarm, but nonetheless, it actually worked, and we were very, very pleased. This is an example of the Backend software. You'd actually, go like Napa and the other hospitals, they have monitors this large, and it'll actually pop up and it'll show the floor plan, the location. You'll see a lot more icons on the floor plan, the person's picture, the demographics about that person, and then the text-based where they actually are in the facility. So the things that we've achieved with this is now the staff basically anywhere in the secure treatment areas have coverage. We know within about 3 meters their exact location on the campus. And so we're able to send people and get them help. We're able to find people really fast. We're able to communicate with them through the tags. We can also, it says, PDAS facilitates enhanced response evaluation. We can decompose events afterwards and actually are deconstruct and look at them and basically say what worked, what didn't work from a forensic perspective. And the other thing, though, is we discovered we really have to protect the data because the staff are so fearful that we're going to use the system to track their performance and whereabouts and things like that. And so we've had to put policies in place that ensure them that it would never be used for that. And the reason we've done that is because it's far too important to us as a safety system. And the one thing I've learned is if they fear it, they won't use it. And it's more important for them to use the system than not. So ultimately, it has made it a safer place. I don't think that you could ever say that it's completely eliminated the problems. It's just made it where we're able to respond quicker. Very proud on a regular basis to see emails that are distributed by the public information officers at the hospitals. And they'll describe an event that'll have occurred where somebody was escorting a patient, they were overtaken by the patient, they trigger the alarm, and people respond. And they're in places where no one would have heard them, no one would have seen them. And because of the technology, people did actually respond and help them, and they weren't injured. Or if they were injured considerably less than if, and it didn't go even further like what happened with Donna. And so it's probably to date, I'd say my probably more successful and favorite project that I've ever done. Staff scheduling is an off-the-shelf technology that we procured from a company called Care Systems, and we're deploying right now statewide. All of our centralized scheduling offices are using it, and then by the end of, I think, like June, early July, we'll have all staff using it, and we'll eliminate paper schedules. It helps us do things like manage all of the bargaining unit rules for things like how we have to give out overtime and so on. And it also will help us. One of our huge problems you may have read about is I think we're like number 2 in the state right now for the amount of overtime that we pay. That's basically driven by our vacancy rates and so on, but having information is the first step to being able to more effectively manage something, and that's what we're really hoping that Assist will do for us. Medical grade network is not a flashy or it's a project where when I first started, we had about 5,000 square foot of data center space out in the hospitals, no wide area network. We now put a single high-speed connection in. The MGN medical grade network project puts in the secondary and tertiary connections, so we can start rolling things like Assist, electronic health record, and other systems out to our hospitals and move away that co-located technology in their facilities. The big thing that I was brought on to do, and my staff and I, it's everything we do. This is probably one of the more strategic places I've ever been, because every project we do points to preparing us basically for rolling out a statewide electronic health record. We're looking to partner with CDCR and the receivership with their deployment and really capitalize on the state's already investment that they've made and are in the process of rolling out there. And look at the benefits. Talk about data sharing benefits. 85% of our patient base move between LA County, CDCR and the receivership, and us. And so if I'm able to get all of their radiology, all their lab work, consults, and things like that, those are things that we're not having to do a duplicate way. And we're all basically paying for that, through taxpayer dollars. So if you get a patient and you don't have a health record for that patient, you have to start from ground zero. And that's basically what happens is patients will come in to LA County or CDCR, and they'll have their record there, but for, not all of them, but a good percentage of them, the record doesn't make it to us in time, and we have to do all that end processing and workup over again. And so if we can basically have our HIE technology in place that allows that data interchange between that, I mean, the savings would be huge. And so, and that's one of the things that we're working towards. Unified Hospital Communications is tied to PDAS. It's basically IP-based PA systems and infrastructure for video surveillance. And it'll actually, PA is really important to PDAS for giving audible alerts and warnings and direction. And all of our systems are aging and dying at this time. And so they need to be replaced. And then it would be very helpful for us to actually have video surveillance of the incidents and so on, not only from a preventive, but also from a data perspective afterwards. We're a really unique entity when it comes to data. Everything, so you remember the bar graph of patient and staff assaults. And so myself and Dr. Warburton is the Chief Medical Officer for the department, and a few others are tasked with how do you make DSH a safer place? And so I was talking to Bill earlier, and I was explaining that what we do is we're attempting basically to build our data repository to include things like anywhere from pharmacy data to our staff scheduling data, our PDAS data, all these different disparate forms of data, but they are tied. And so we could look at, let's say in a hospital, you have a specific unit and suddenly there's a spike in violence. And we need to know why. And so we look at it and we'll see that possibly the doctors in that specific unit are prescribing specific psychotropic drugs that may actually have a side effect of aggression. It may not be being prescribed in any other units. The overtime may be high, and vacancy rate in that unit, and so our staff are working long hours and not as security aware because they're tired. So any different causes of the why something has happened, so then we can make an informed change and then watch the downstream data to see if it actually had the desired outcome and effect. And so now we embed our data people in basically all of our systems projects. Because we really don't look at them as though we're just taking a paper-based process and moving it to the electronic. It's what do you basically get out of this at the end of the day that's usable? And our data people make sure then that these systems are actually collecting the proper data. So we have someone embedded from our data management office in our PDAS project and so on. And so it's, I think, very helpful for us, and it positions us to move more into the day where we're actually having a repository of historical events and have analyzed them and say we have specific indicators and we've measured thresholds where it's, if we see those same key indicators hit those thresholds again, it's possible this type of event may occur. So we, in a more proactive, through predictive analytics, can actually maybe possibly prevent some of these things. So it's all about data at DSH. We're very much developing different analytics organizations. I have mine, the clinical side of the house is starting to develop their analytics leadership, and they work very much with mine. And then there's even in our admin section, an analytics unit that's providing things like answers to the legislature and Department of Finance and people like that. So I'm very proud of what we've done so far with data and what we will do in the future. And I'd say that a good portion of our projects will come out of, in some way or another, data-related projects. An example of, and I said earlier, is the leader over our PART system is in the room today, and she's actually our data management office chief, and she's running an app case management development project. So that's kind of an example of how we view data in our department. Plus, she's also competent as hell, so that's kind of a good thing. So, all right, so here's the typical slide of information technology at a glance. I have 134 staff, which was kind of depressing when I saw that, because I thought I had a lot more than that. And which I had to put this in there, and it's not I'm whining about a 91-to-1 support ratio, but I like what my manager said yesterday, and it's kind of a cool take on this is it means that we kick ass. We have a small number of staff, and the amount of stuff we're able to accomplish with very competent and driven staff is amazing. And this is hands down, and I apologize to other people that have worked for me when I say this is probably one of the better teams I've ever had work for me today. And I'm constantly amazed that they were already at the department. And so I didn't bring anybody with me. They just weren't in the roles that they are in today, but they are some of the most competent people I've ever had work for me. So $72 million budget for my organization, but that also includes the projects that we're running. So it's not just my operational budget. So it's kind of misleading. So that's my presentation, and I'll open it up now to Q&A.
Jamie, thank you. That was a fascinating presentation.
Thank you.
I know you travel a lot, so we're lucky to have you here today.
Thanks.
Okay, so let's open it up. First question, anyone?
Well, if there are no questions, that's it was such a thorough presentation.
On your electronic health records, you're talking about leveraging what CDCR is already doing.
Correct.
So I'm assuming it's the Cerner solution that they're implementing now.
Right.
Are you going to have a separate procurement for the implementation, or are you going to extend that contract to simply roll into your?
We haven't made that decision yet. So right now we're in the early stages of the feasibility development. We're working with Cerner and CCHCS, the receivership, and CDCR to basically map out that project. The intention is to use their physical implementation and be a part of it. Cerner gives you the ability to partition out organizations where, and this was kind of a dangerous thing. I never wanted to tell my hospitals that the technology could allow them actually to run as siloed organizations. I remember when I first saw that, I said, well, I'm gonna lie to my hospitals and tell them I can't do that, or we didn't buy that module. And it luckily can do that, and so it allows us then to leverage what they've deployed there and to use it in our way. They're, if you think about it, they're kind of like the MedAlert type of outpatient clinics in the hospitals. We are a real long-term care acute hospital, and so they're very different. Yes, they have pharmacy, we have pharmacy, but how they actually dispense meds and things like that are actually different. And so it's how do we actually handle that? And then the technology can do it. It's more of then, for the first time, having two state agencies develop a very effective governance model of how do you then govern that technology. And then the really cool thing that would come out of that is sharing data then between CDCR and my organization would already be there, with the hope then that we then, the two of us would in turn approach LA County and basically try to get them to get into a data sharing agreement with us and exchange patient records with us as well for inbound and outbound, so.
So Jamie, I've known you for a long time, and you always seem to be involved in learning about the organization and the business you're in. I'm kind of curious as to how long have you been there? Over 5? 3 years?
3.5 years.
Yeah.
So
when you got there, the IT was in a certain state in a relationship with the business. It's changed in 3 years. You've had some success stories.
Yeah.
Where do you want it to go, say, for the next 2 or 3 years?
Well, I don't really think of from the positioning of the IT organization. I think we're finally, I'd like some more staff, but what CIO wouldn't? Imagine what I could do with more. We want to basically get the prize, which is our electronic health record, and then deploy that. We see that as potentially a long project for us because at CCHCS, when I was there, we deployed things like radiology and those what we call ancillary health systems. We don't have any of those at DSH. So for us, an electronic health record is also going to include all of the PACS risk technology for radiology, our lab technology, our pharmacy technology. And so we're looking at, and this is kind of contrary to what I prescribe the state doing for projects. It's about a 7 to 9 year project as it's spec'd out. But that's because it's just too big, and we're chunking it out where, let's say if this gets deployed and then this doesn't get approved, what's been deployed is still sustainable and stays in place. And then we can, come to it at a later date and pick it up again. But yeah, I mean, that's it. I've done things differently here where I would say this is the most sustainable organization that I've developed to date. I've always heard from friends that when I leave a place that things don't run the same way after I'm there. And this is the first place where I think that if I left, the leadership that I have in place would very much carry things on and keep things running as they are now, and it's and have the same mindset and so on.
One more question here at the back of the room.
I think you mentioned that you spend a lot of your time doing governance,
I do.
and I'd like to get some idea about the structure of your governance committees, top down, bottom up, size, frequency of meetings. How do you do governance?
Well, we started with, I used the technology, so we're not supposed to force change with technology. This is the first place where I've actually found that's probably one of the best things to do. And so we learned right off the bat that we had the ability to drive that organizational change better than any of the other organizations in the department. And so PDAS was the first real catalyst. And so now this week, as an example, we had a PDAS governance board meeting, which is the 5 executive directors of the 5 large hospitals and myself. And we meet monthly. And what's amazing is the amount of actual policy that comes out of that group and how our systems are used, how our data is accessed, and decisions that we make. Like we decided recently that we're rolling out whistles statewide because, in my opinion, you don't back up technology with technology, because if you have like a catastrophic outage at one of our hospitals for a sustained period of time, anything that has an electrical need is going to stop functioning. So it doesn't, you don't put things out there that require batteries. So our staff now, and we decided to issue statewide whistles. And they do this at CDCR, and we do it here now as well. And we had to write the policy and then I spent way too much time in front of different bargaining units negotiating the language and things like that. And then, but it's really cool to watch the 5 executive directors, because in the beginning, it was kind of difficult to have them agree on anything. And now they've learned all those things like back channel lobbying, and I'll get a phone call from 2 of them prior to us having like a vote on something to try to sway me towards. And what's funny is I only have 1 vote too, so it's not as though I can really affect the outcome of something. But they're now a very effective body, and we're using them now on the Assist project and other things as well as on the electronic health record and project. And so we're trying to train them how to make collaborative decisions. And the one thing when we first got there, in healthcare, especially mental health, they manage to consensus. And consensus is everybody has to agree or you don't do anything. And a friend of mine who's a very, very smart man said that is an immobilizing concept that you should never try to achieve, and that's always stuck with me. And so I've been trying to teach that, you basically, at best, can get a majority, and sometimes we've actually set policy with only 2 of the executive directors in agreement. We're like, okay, there we go. That's how we move forward, and 2 of you agreed, that's good enough. And so it's now teaching us to manage the outliers of how do you manage that dissent to the decisions that have been made. How do you teach then everybody who's responsible for those decisions to stand the line together and represent them, even though they may disagree with them, as their own decision. It's an organizational decision. And I'm very proud the amount of headway our department has made. But the primary upper level governance group is basically the executive directors and the deputies of the department, and I'm one of the deputies. But most of the hospital-centric governance is the 5 EDs and myself. Sometimes we bring in the 3 EDs from the psych facilities, depending on the subject matter.
So on the slide where you showed staff incidents versus the patient incidents. I noticed that there was a decrease with the staff incidents. And I know PDAS is still rolling out, you're not quite done, but are you already starting to do some data analysis on whether they're directly attributed to that?
We don't know yet, but what we do see is we call it the PDAS effect, at least for morale. So we do these annual statewide surveys with our employees, and part of them is about, do you feel safe in the workplace? And it was very evident at Napa after we deployed PDAS that there was a huge spike, and they carried it forward and were much higher than the hospitals that didn't have PDAS. I've not seen survey results yet from Patton and Metro, where we've also rolled out. So I'd like to see the effect there to see if it carries forward, but it was very prevalent. I mean, it stood out. They were literally I think it was 10 to 15 points above the other hospitals, and just general consensus of, I feel safer at work, so.
Next question. Okay, I have a question. This is one of our standard TechWire questions regarding leadership. You're one of our more senior CIOs in the IT community.
Thanks.
I know that you teach with your tenure.
Okay.
I know you teach at the Project Academy, have taught some classes recently. Can you talk about your leadership philosophy, your approach to leadership?
Well, I definitely believe that, if we've been doing this for a long time and have been doing it successfully, then, we really have an obligation to kind of develop the next bench, of people. And there's a lot of people leaving, and so a lot of new people that are coming in. And, it's amazing to teach them, basically as an example, just how to interface with the vendor community, and, and how you effectively have to give FaceTime and things like that, or people believe that it's not worth providing a response on an RFO or an RFP, and they just want to run things fast, and they don't realize, the message that it sends. And it's just, that's one example. And so I discovered about 2-3 years ago that I was spending a lot of time mentoring people and kind of just answering their questions, and actually discovered I liked it. And so I've been kind of doing a lot of things like this, teaching, writing articles, and so on, and just trying to kind of teach people to do things maybe in a more creative and effective way, at least from my perspective. And basically that's what I'm doing.
Alrighty, one more.
So Jamie, given the amount of challenges you have from a safety standpoint, do you see more automation to, you mentioned the psychiatrists and the telehealth in some regard, but it would seem that less human resource and more technology in the institutions would serve better to protect. Do you see a shift, or are you always going to need that 50% more resources to staff, or do you see some combination of both?
From an IT perspective?
Well, even from operations is what I'm thinking about, because you're saying the retention is tough,
right.
50%. Is there some other ways to solve that problem?
Well, if you look at Kaiser hires, pays more, and has recruitment and retention budgets, our bonuses that we just can't meet. IT as well, hiring and retaining people that are HIT, I can't, with the general classifications in IT in the state, compete with that as well. If I bring people in and try to develop them, they would just leave and go into the private sector and make a lot more money than what I can pay. Plus, I don't think you should really be developing your staff on life-dependent technology anyways. So healthcare, I don't really see the numbers going down because of the type of population we have. And our doctors are very, very resistant, to be honest with you, to use telepsychiatry, telehealth. In the mental health establishment, they firmly believe that you really have to have that face-to-face interaction. And it's like playing a poker game. You have to see all the tells and everything that the patient's giving you for you to basically make a proper diagnosis. And so ironically, when I came over from the receivership, I thought, that would be an easy win. We'll just start deploying telemedicine here. And at the time, Kate was, let's just say, very passionate, Dr. Warburton, about how much she hated that idea and didn't want it to occur, that I actually wrote little frowny face emoticons and don't ever bring this subject up again with Dr. Warburton. And I now remind her of that, but she finally got to a point where, and this is, I guess, my organizational motto, is she said, well, it was better than nothing, because in some places that's actually what we had. And to get somebody through technology was better than not getting any treatment at all, and would be irresponsible to not give them treatment. So that is our model. We're actually better than nothing, and that's what we strive for. And but now, I didn't even know this. Her chief of telemedicine wrote this huge article in support and stuff, and I was like, wow, how come I didn't see that? And that was like very cool. And she's talking about how telemedicine and telepsychiatry will end up transforming our organization and so on. So not only are they supportive, they're now actually out there actively marketing it and so on. So.
Okay, last question. Anyone else? Last chance? Alrighty, well, let's go ahead and wrap it up. Thank you again to Jamie Mangrum for giving us a great presentation.